This is a preoperative chest X-ray on a 41-year-old female patient known for colon cancer. There is a right mediastinal bulge, which could be mediastinal, raising the possibility of lymphadenopathy from metastasis or other causes, or it could be a parenchymal lesion, such as lung cancer, that is adjacent to the mediastinum. However, this is neither a lymph node nor a parenchymal lesion, and the case has more than that. Before we continue with our case, let's talk a little bit about anatomy. This is the aorta enhancing on a CT scan of the chest with two adjacent structures. This right-sided structure is the azygous vein. The left-sided structure is the hemiazygous vein. At one point, the hemiazygous joins the azygous, as you see here, and continues as a single azygous vein. This azygous vein continues in a right paraspinal or a prespinal location all the way superiorly before curving anteriorly above the right mainstem bronchus to empty into this structure, which is the SVC. Again, this is the trachea, this is the right mainstem bronchus, and here's the azygous curving on top of it. So this is the azygous on a coronal image, and it goes all the way up and curves on top of the right bronchus. And this azygous knob or azygous arch joins the SVC. Knowing the normal azygous anatomy on CT makes it easier to understand the anatomy on a normal chest X-ray. So this is a chest X-ray on a different normal patient. And now you can understand why you see the azygous the way you see it here as either a rounded or oval structure. So the azygous lives in the right tracheobronchial angle here, and this corresponds to what we just saw on a CT scan as the azygous arch curving anteriorly to join the SVC. A normal azygous should not be distended, and the normal size is 1 centimeter or smaller. Now let's go back to our abnormal case, and although we thought this could be mediastinal or parenchymal, now you know what it is. Measuring what could represent the azygous arch here yields a number of about 14 millimeters, which is large. Like any vein in the body, the azygous vein could distend from physiologic or abnormal causes. So what is the differential diagnosis for an enlarged azygous arch on a chest X-ray? First, this could be physiologic, such as a hyperdynamic circulation in pregnancy or hypervolemia. Second, this could be technical. If the patient is supine, you'll have distension of the veins. Cardiac and pericardial abnormalities are common reasons for distension of the azygous vein. Examples include congestive heart failure or right-sided heart strain. Constrictive pericarditis and pericardiac tamponade are also causes. Remember, the azygous for a radiologist is equal to the JVP for a clinician. So that's a good way to remember cardiac causes, since right-sided heart failure gives you an elevated JVP and a distended azygous. Another category would be obstructive. If you have venous obstruction such as obstruction of the SVC, the azygous could act as a collateral. Distension of the azygous may happen due to congenital causes. These include something called azygous continuation of an interrupted IVC. We'll talk about that more. Anomalous pulmonary venous drainage into the azygous instead of going into the left atrium. This later entity is one of the types of partial anomalous pulmonary venous return. Finally, the azygous may distend due to vascular causes such as fistula with aorta or portal hypertension. Now, looking at the CT scan of this patient, you'll notice that the patient does not have an IVC and he has this distended azygous. And this is the distended hemiazygous joining the azygous on the right side. And now this hugely dilated azygous assumes its normal course to go all the way superiorly and curves above the right bronchus to join a distended SVC as well. And this is a coronal image on this abnormal patient showing this huge azygos that's almost equal in size to the aorta, which curves at the right tracheobronchial angle to join the SVC. This is a congenital entity called azygos continuation of an interrupted IVC. In this condition, the IVC is either partially or completely absent, classically the hepatic and suprahepatic portions. So the azygos and sometimes the hemiazygos take the responsibility and the load of draining the venous flow back to the heart. There are variations in how the IVC is absent or interrupted. For example, in this case, you don't see the hepatic IVC, but there's a small suprahepatic portion that drains into the right atrium. So today we learned a neat entity called azygos continuation of an interrupted IVC, but we learned more than that. Now we know our normal azygos anatomy ascending along the spine all the way and above to drain into the SVC. We know that the azygos arch curves on top of the right main stem bronchus, and it should not exceed a size of 1 centimeter. We also learned the differential diagnosis for distension of the azygos, including technical factors, physiological factors, congestive, cardiac, and pericardial etiologies, obstructive etiologies such as obstruction of the superior vena cava, congenital such as azygos continuation of interrupted IVC or anomalous pulmonary venous return, and unusual vascular causes such as portal hypertension or fistulization with the aorta. Thanks for watching. More cases later this week. This is a frontal chest radiograph of an adult patient who presents with shortness of breath. This is the lateral chest radiograph on the same patient. There is blunting of both costophrenic angles consistent with small bilateral pleural effusions. Importantly, you see bilateral, relatively well-defined scattered nodular opacities. Here's a close-up of the nodules. Here's a relatively well-defined discrete nodule, for example. Multiple others are seen. The right side is involved as well, and here's another larger opacity. There is confirmation of bilateral pleural effusions on the lateral projection, since you don't see the costophrenic angles here. Multiple nodular opacities are also appreciated on the lateral as well. Whenever you see bilateral, well-defined nodules and masses in the lungs, the major differential diagnosis is that of metastasis. The second diagnostic possibility would be infection from atypical organisms such as fungal infection or tuberculosis. Now, this is all fair and good information. The main reason I'm showing this case is not for that. Have you noticed any additional abnormality on the lateral X-ray? When performing a lateral projection, the patient is asked to lift his arm up so that it does not project on the hemithorax. This is the soft tissue of the arm, and you're supposed to see humeral bone in this area. Here's a close-up. The humeral bone is not there. It's destroyed by a lytic process. This part here is what remains of the humeral diaphysis. So not only that you have what looks like metastatic lung disease, you also have metastatic bone disease as well. Metastasis from various primaries could be lytic, sclerotic, or mixed. The commonest lytic metastasis is that of renal cell carcinoma. And this patient was discovered to have a renal cell carcinoma with metastasis to lungs and bones. Here's a transverse CT image in bone window showing you a normal left humerus that is partially seen, while the right humerus is totally replaced proximally by a soft tissue lytic lesion. We learned from this case that the main differential diagnosis for bilateral well-defined nodules and masses is that of metastasis. Other etiologies for such an appearance are less common, and the second most common would be that of infection. Infections from fungal or mycobacterial organisms may give you such an appearance. Most important point from this case is that the lateral is very useful in confirming whatever you see on the frontal radiograph. Another important point is to look at the periphery of the film, whether you're looking at a frontal or lateral chest X-ray. Sometimes the peripheral finding is very important, and it's a finding that could help you clinch the diagnosis, such as metastasis here. Thanks for watching. Your comments are really appreciated. More cases later this week. This is a quick case for senior residents, but I'm sure juniors would benefit from the teaching points here as well. Although there are multiple features, please concentrate on the sternum. I showed the bone windows. This is the soft tissue window showing the sternum as well. If you compare the sternum to the rest of the bones, you'll notice that the cortex is thick, the sternum is expanded. And since you see bone expansion, your major consideration would be that of Paget's disease. The classic triad of Paget's disease is bone expansion, cortical thickening, and coarse trabeculations. However, looking carefully at this case, you'll notice that you do not have coarse trabeculation. In fact, the inner marrow looks extremely clean, and the bone marrow on soft tissues has this very low density that is consistent with fat. This case is easier when you know the history, but the hint is on the image. This is the normal right breast. This is absent left breast from prior mastectomy for breast cancer. And the patient received radiotherapy. The sternum was included in the field of radiotherapy. As a result, radiation-induced bone changes are seen in the sternum. There are various manifestations of radiation-induced bone changes. Long-standing changes, such as what we see here, are well described. These may include bone expansion, cortical thickening, periostal reactions. Even coarse trabeculations with radiation have been described, which is something that's absent here. One famous feature of radiation is that it kills the marrow, and the marrow gets replaced by fat. So this is a feature that we see here, replacement of the marrow by fat, which is not a known feature for Paget's disease. Remember, you could see a replacement of the marrow by fat on MRI as well. The first thing that we learned is reading images should be combined with the clinical information. We learned that the classic features of Paget's disease of the bone include bone expansion, cortical thickening, and coarse trabeculations. We also learned that these findings may be seen in radiation-induced osseous changes. I will hopefully talk more about Paget's disease and differential diagnosis of bone expansion in future clips. Thanks for watching.